Hello everyone and welcome to today's webinar, Applications of Metagenomic NGS in Immunodeficient Patients. I am Kaylee Bach of Labroots and I'll be your moderator for today's event. Today's educational web seminar is presented by Labroots and brought to you by BGI Americas. To learn more, please visit www.bgi.com/US. We encourage you to participate today by submitting any questions you may have during the presentation. To do so, simply type them into the Ask a Question box and click Submit. We'll answer as many questions as we have time for at the end of the presentation. You may also submit any technical issues here as well if you have trouble seeing or hearing the presentation. And with that, I'd like to now welcome our speakers. Dr. Lili Gao, Associate Chief Physician, Tongji Medical College, Huazhong University Science and Technology. Also, Dr. Chen, Associate Professor, Tongji Medical College, Huazhong University Science and Technology. Dr. Gao, Dr. Chen, thank you for joining us. You may now begin your presentation.
Good morning, everyone. My name is Lili Gao. I'm a doctor working in the Department of Hematology, Tongji Hospital, Tongji Medical College, Huazhong University of Science and Technology. Today, I would like to share with you one case and one of our study on the clinical use of mNGS. Let's start with a case. This is a female patient, 50 years old. She has been diagnosed as diffuse large B-cell lymphoma for 1 year. The primary lesion is the breast. In April 2019, bilateral breast masses were found and the quadri resection of both breasts was performed, and the lesion review was that neuroplastic lesion combined with morphology and immunohistochemical results consistent with diffuse large B-cell lymphoma. The FISH also showed that c-MYC, BCL2, and BCL6 were negative. And the PET-CT showed that multi-high metabolic shadows SUV max 70.5 in bilateral breast, increased lymph nodes, and enlarged SUV max 5.6 in adjacent left axilla, which were consistent with the sign of lymphoma. Bone marrow aspiration, flow cytometry, and biopsy showed that there was no lymphoma bone marrow invasion. So this patient was diagnosed as diffuse large B-cell lymphoma. She underwent 6 courses of R-CHOP, 2 courses of R-maintenance treatment. Then she had her first relapse and was given second-line chemotherapy, RDHAP, followed by autologous hematopoietic stem cell transplantation and CAR-T therapy. In the myelosuppression phase after CAR-T treatment, she developed agranulocytosis with fever, nausea, and vomiting. CRP and PCT were slightly elevated. We consider that the patient might have infection and threatened anti-infection treatment. The patient's fever was under control. 1 week later, the patient had sudden pain in the wrist, back, and abdomen, and then she had confusion and fever, and had CT suggested mild cerebral atrophy. The patient had a continuous fever and confusion. What was the pathogen of the infection? As we know, multiple blood cultures were negative. G and GM tests and the CRE were negative too. We considered that the patient had an intracranial infection, so we performed a lumbar puncture. The CSF results showed elevated glucose, lactic acid, and protein, and no obvious abnormalities were observed in cytology, bacterial, and fungal cultures. The CSF was tested for mNGS, and HHV6B were detected with more than 120,000 reads. At the same time, mNGS in peripheral blood were tested, and HHV6B were also detected, which was consistent with the result of CSF. So, what is HHV6B? HHV6B is a member of a Herpesidae family that replicate in activated CD4 positive T lymphocyte. There are two subtypes of HHV6, 6A and 6B. The majority of confirmed primary infection and reactivation events were caused by HHV6B. HHV6 enters lently after primary infection and may be reactivated during host immunosuppression, especially after allogeneic HCT. Monoencephalitis was one rare manifestation of HHV6B infection. A high HHV6 viral load in the CSF supports HHV6 as the causative factor. HHV6 infection is associated with mesotemporal and lobe epilepsy. About half of HCT recipients and 20% to 62% of solid organ transplanted recipients developed HHV reaction syndrome. Reactivation of HHV6 usually occurred 2 to 4 weeks after transplantation. How is HHV6 infection treated? Those with normal immune function do not need specific treatment. Antiviral is required if HHV6 infection is associated with complications such as encephalitis or myocarditis. Immunosuppressive therapy should also be discontinued or reduced. Ganciclovir or phosphonic acid are generally superior to cidofovir. After antiviral treatment, anti-infection hormone is central. The patient's neurological symptoms were significantly relieved. Digital PCR can be used to monitor the HHV6B nucleic acid quantification. We can see from this picture that following after treatment, the nucleic acid load of HHV6B in patients' peripheral blood gradually decreased to 0. As we know, hematology patients have unique clinical characteristics. Infection in patients with hematologic disease is often acute onset, account lesion, atypical clinical manifestation, and a mixture infection. They had high risk of bloodstream infection due to CVC implantation, cutaneous mucosal barrier breakdown, and the intrinsic factor of disease. When bloodstream infection occurs, it is very important to find the infectious agent in time to control the infection. Traditional pathogen detection methods included the following four types. First, blood culture. The positive rate of bacteria and fungi was about 10%, and the cycle was 1 to 7 days or even longer. At present, this test is routine clinical test. Second, mass spectrometry. About 1,000 known microorganisms, some of which cannot be identified as species, dependent on culture. Third, immunological detection. Mycoplasma, chlamydia virus is central. The cycle is 1 to 3 days. There is a window period and high false positive. Fourth, PCR or gene chip. Detection of 1 to dozens of pathogens. The type is limited and the cycle is several hours. mNGS, shorted for metagenomic next-generation sequencing, is increasingly used in clinical microbiology diagnosis. When performing mNGS detection, the DNA of all microorganisms was directly extracted from peripheral blood samples, and the genetic composition and the community function of all microorganisms contained in the samples was studied using genomics research strategies. mNGS has four advantages: high sensitivity, high specificity, wide coverage, and strong detection ability. Then, what is the application of mNGS in immunocompromised patients with hematologic disease? To answer this question, we designed a retrospective study. This figure shows the flowchart for enrollment, and this table shows the characteristic of 256 immunocompromised patients with suspected infection. We can see that many kinds of hematologic disease were included in our study. The pathogen detection rate was 73% based on the result of mNGS, and the overall infection type were mainly simple virus infection and mixed infection. 66% of these patients received antibiotic modification based on mNGS result. The comparison between mNGS and CMT was restricted to samples taken simultaneously or on the same day. Conventional methods included blood culture and PCR. The coincidence rate of mNGS and CMT was 57.4%. The positive rate of mNGS was higher than that of CMT. This picture shows that half of the patients were mNGS positive and CMT negative. Less than 1% were mNGS negative and CMT positive. About 30.9% were double positive and 26.2% were double negative. For the double positive subset, pathogens detected by mNGS and CMT matched in 30 patients and mismatched in 3 patients. mNGS detected more pathogen in 45 patients, and the CMT detected more pathogen in 1 patient. There are several discord results by mNGS and CMT. Ralstonia picati was identified in the blood culture of patient 1, but no pathogen was detected by mNGS. Further analysis of the original mNGS data showed that Ralstonia picati was ranked second by unique rates among species of bacteria. It was not interpreted as a pathogen since Ralstonia picati was a common background bacteria. Salmonella was identified in the blood culture of patient 215, but no pathogen was detected by mNGS. This could be because Salmonella is an intracellular bacterium with a cell wall, which hindered the extraction of pathogen nucleic acid. DNA damage has been reported in Enterococcus faecium found in human blood, which might be the reason why mNGS failed to detect infectious Enterococcus faecium in patient 20 and patient 200. In patient 6, the original data showed that mNGS also detected xenotransformers maltophilia, which ranked 74th in frequency among bacteria, but only the 10 most abundant bacteria were listed in the mNGS result. In patient 137, RT-qPCR detected CMV DNA at fewer than 400 copies per millimeter, the critical value. Thus, the CMV load in this species was very low, for which CMV was not detected by mNGS. From this picture, we can see that the 5 most common causative viruses were CMV, EBV, HSV1, BK virus, and HHV6B. The 4 most abundant pathogenic bacteria was Pseudomonas aeruginosa, Klebsiella pneumoniae, Xenotrophomonas maltophilia, and Acinetobacter baumannii. And the 2 most commonly detected fungi were Pneumocystis jirovecii and Candida parasilosis. We next investigate the distribution of common pathogens that infected patients after different therapies. The 5 most popular subgroups were ASCT followed by CAR-T, HSCT, CAR-T, lymphocyte, and ALCT. The detection rate of BK virus in the ASCT followed by CAR-T and the HSCT group was significantly higher than that in the chemotherapy groups, and the detection rate of HHV6B in the ASCT followed by CAR-T and the ASCT groups was significantly higher than that in the CAR-T group and the chemotherapy group. We concluded that it was more likely for patients who had HSCT, whether followed by CAR-T, than those who had not, to be infected by BK virus and HHV6B. There was no significant difference in the positive rate of bacteria or fungi between the 5 groups, although the lymphoma CT group exhibits a higher detection rate of Pneumocystis jirovecii. Multi-pathogen infection was common in immunocompromised patients. From this picture, we can see that about 55 patients infected by pathogen of multi-species, 38 patients infected by multivirus, and 4 infected by multibacteria. Multivirus infection was the most common, followed by viral and fungal co-infection and viral and bacterial co-infection. In CMV virus co-infection, the most frequent other viruses were EBV, BK, HHV6B, and HSV1. In CMV fungus co-infection, the most frequent fungus found with CMV was Pneumocystis jirovecii. With the help of our friends, we are fortunate to publish the article in the Journal of Infection. In addition, 2 other teams in our department also studied the detection efficiency of mNGS in transplantation and CAR-T patients, and published their article in Frontier in Cellular and Infection Microbiology and Cancer Communications. mNGS can change the future diagnosis and treatment of bloodstream infections. The multidisciplinary telemedicine cloud platform assists in precision diagnosis and treatment, combined with regional epidemiological data and population pharmacokinetics. Individualized and precise anti-infection treatment plan was developed. Precision diagnosis and treatment required multidisciplinary collaboration. In addition to clinician analysis, microbiologists, radiologists are also required to participate. Only by working together can we find the infectious pathogen as early as possible and improve the progressive of the patients. That's all. Thank you for your attention.
Good evening or afternoon, ladies and gentlemen. It's my honor to be invited to give a speech in the conference. My topic is Introduction of Pathogen Metagenomic Sequencing, Solution for Metagenomic Next-Generation Sequencing to Infectious Diseases in Clinical Application. I'm Dr. Chen from Department and Institute of Infectious Disease, Tongji Hospital, Tongji Medical College, Huazhong University Science and Technology, Wuhan, China. During the diagnosis and treatment of infectious diseases, pathogen identification plays a pivotal role. In conventional pathogen diagnosis model, clinical practitioner usually diagnoses the potential infection sites based on patient's symptoms, iconographic tests, and biochemical tests. However, the golden criteria of pathogen identification are still given by isolation culture, smear testing, serological testing, and PCR or gene chip. Those conventional pathogen identification tests shows excellent performance in pathogen identification, but still shows some limitations in clinical application, such as long test awaiting time, long sensitivity, window period of sample acquirements, and limited targets. To better meet clinical needs in pathogen identification, metagenomic next-generation sequencing was developed in last decades. Pathogen microorganism sequencing, abbreviated as PM-seq, was developed and widely used as a solution for metagenomic NGS to infectious disease in clinical application. PM-seq shows some advantages in clinical practice based on metagenomic NGS to test microorganisms with prior knowledge or assumption. With a single test sequences all microorganisms in a sample without a lead for culture, the databases are much larger and contain curated sequences from more organisms rather than a set of sequences from a single gene family. Lastly, PM-seq gives a potential way to detect unknown and rare pathogens. The composition of PM-seq solution includes kits for pathogen nucleic acid extraction as DNA or RNA library preparation. Then the prepared samples will be tested by sequencing platforms or machines with different lengths or flux. Beyond wet lab process, the acquired data will be analyzed and transformed as information that doctors understand via automated analysis platform or intelligent bioinformatic analysis, severe, developed for analyzing sequence data generated from PM-seq testing. According to the merits of PM-seq, it could be well adopted in complicated and difficult to identify infectious disease, severe infection such as severe pneumonia, meningitis, or sepsis, as well as in immunocompromised patients. Direct high-throughput sequencing or infected specimen through microbial-specific database comparison and intelligent algorithm analysis, obtaining species information of suspected pathogenic microorganisms and providing comprehensive and in-depth reports for rapid and accurate diagnostic of difficult and critical infection, and promoting the rational role of antibiotics. According to the type of nucleic acid extracted, it is divided into DNA detection process and RNA detection process. The DNA detection process is applicable to the detection of intracellular parasite bacteria, such as Microbiome tuberculosis, and so on. The RNA detecting process applicable to detection of RNA virus, such as influenza virus, respiratory syncytial virus, coronavirus, and others. The suspected RNA virus infection detection process should be used. Based on detected data from PM-seq, analysis pipeline could be adopted for final reporting. The host filtering, pathogen identification, background microorganism identification, and report generation are key processes. During the course, PMDB host database, PMDB pathogen database, and PMDB background database are used for pathogen identification. The PMDB host database includes International Universal Human Reference Genome, BGI self-assembled Huazhong genome, and mRNA-tRNA sequences. PMDB pathogen database includes over 10,000 bacteria, over 1,000 fungi, over 5,000 viruses, and 280 parasites. PMDB background database includes large sample data analysis, construction of thousands of real samples, years of clinical practice accumulation, engineering bacteria, common microorganism in laboratory environment, and the corresponding microorganism of sample type. Short-term consumption is one of the other important characteristics of PM-seq. Nucleic acid extraction normally uses 1 to 1.5 hours. Library preparation for DNA sample use 2.5 to 6 hours. The RNA sample for 5 to 6 hours. The process of sequencing spent 6 to 15 hours, and the total test awaiting time for PM-seq normally less than 24 hours, which would benefit timely diagnosis and treatment of patients with infectious diseases. The applicable platforms are chosen according to outthroughput, sample size, sequencing time, feature, and the scenario of clinical leads. Meanwhile, the PM-seq Halos processes user-friendly interface with facilitated quick and practiced operation. Easy operation and convenient data management are the other important characteristics of PM-seq. Includes the operation of input task information, check data analysis status, view and download generated reports, and lastly, the manage information about the user. This slide shows the PM-seq demo reports, which include target pathogens for identified, and also the comprehensive displayed all kinds of DNA pathogens detected, including bacterial, fungi, DNA virus, parasites, tuberculosis complex, mycoplasma, and interpretation of pathogen information for research use only. This is all my presentation. Thanks a lot for your attention.
Thank you, Dr. Gao and Dr. Chen, for your informative presentation. We will now start the live Q&A portion of the webinar. If you have a question you'd like to ask, please do so now. Just click on the Ask a Question box located on the far left of your screen, and we'll answer as many of your questions as we have time for. All right, so let's get started. Dr. Gao, our first question here asks, in your talk, you said mNGS missed detecting a bacteria because it was not interpreted as a pathogen. But in this case, the CMT worked. Is there a clinical guidance that helps clinicians decide when mNGS should be used or not be used for bacterial diagnosis?
Thank you. That's a very good question. mNGS cannot completely replace conventional pathogen detection items and needs to be combined with traditional methods to improve the sensitivity and the specificity of pathogen diagnosis. First, for new, rare, difficult infectious disease and the immunocompromised patients, mNGS can significantly improve the detection rate of pathogens. So mNGS can be used as a first-line detection method for the above disease. Second, for critical ill or immunosuppressed or immunodeficient patients suspected with infection in clinical practice, it is crucial to clarify the etiology result early. It is recommended to collect samples of suspected infection sites for mNGS while improving traditional laboratory and molecular biology testing. Thank you.
Great, thank you. I have another question for you here. Would you explain why the mass spectrometry method cannot identify some of the microorganisms as species? I thought the high resolution of this method can resolve species of distinct masses.
Thank you. As we know, if the microbial strain to be tested in clinical practice have a unique structure or have extremely similar patterns, or are rare strains, new strains, mixed strains, etc., mass spectrometry technology will be difficult to detect, or there will be some errors. This is because the database is not perfect, and the standard stream patterns in the database are limited and the data is insufficient. Therefore, the database of mass spectrometry technology will still need to be continuously improved. There may still be some errors in microbial testing, and it is difficult to identify some uncommon bacterial strains.
Great,
Thank you.
Next question. In what situations mNGS is not a good method to detect a pathogen?
First, because of high detection cost and its own shortcoming, mNGS cannot be used as a first-line detection method for mild infectious disease, nor as the first choice. Second, for patients with focal infection, routine infection indicators and traditional pathogen testing should be completed first. If the pathogen diagnosis results are still not obtained and the clinical treatment effect is poor, mNGS can be used as the second-line preferred detection method. Third, for patients with higher suspicion of viral pneumonia or continuous disease progression, multi-PCR testing for respiratory virus can be completed first. If it is negative, mNGS should be performed, and the nucleic acid RNA reverse transcription should be performed simultaneously. Thank you.
Great, thank you. Looks like we have time for one more question here today, so we'll wrap up after this one. This question asks, can you further comment on the combination of mNGS and CMT clinical results for improving diagnostic accuracy? For example, would the accuracy have to do with which species we are looking at?
Thank you. That's a very good question. As we know, mNGS cannot completely replace conventional pathogen detection items and must be combined with traditional methods to improve pathogen diagnosis, sensitivity, and specificity. And there are differences in mNGS detection efficiency for different pathogenic microorganisms, with mNGS having a higher sensitivity for virus detection. Because the detection efficiency of sink-walled bacteria is relatively low, high sensitivity PCR is still required for sink-walled bacteria, such as Mycobacterium tuberculosis. That's all. Thank you.
Great. Well, that concludes today's Q&A session. Thank you again, Dr. Gao and Dr. Chen, for your time today and your important research. We would also like to thank Labroots and our sponsor, BGI Americas, for underwriting today's educational webcast. Before we go, I'd like to thank the audience for joining us today and for their interesting questions. Questions we did not have time for today and those submitted during the on-demand period will be addressed by our speaker via the contact information you provided at the time of registration. This webcast can be viewed on demand, and Labroots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. Until next time, take care, everyone. Goodbye.
Goodbye.